Hi, good afternoon. I'm Dr. Abad. I was asked to give a discussion on when to start during an OI. So the objective of this study is really very simple, or this discussion rather. We want to determine the optimal timing of ARV in the setting of the most common opportunistic infections, or OI. We will go over PCP, tuberculosis, of course, cryptococcus, and others. There's about 28 or 29 OIs. We won't be able to go over all of them because it's such a laundry list and we have so little time. So I'll just give you a table that hopefully will help patients when they come into your clinic. So when we go over the deck of slides to follow, we'll go over recommendations. We'll go over why these recommendations are done, or so the evidence behind it, highlight certain key points as we go through the slide deck. Now, the content of this discussion is taken mainly from the adult OI treatment guidelines. As you can see there, they actually enumerate the evidence and the level of evidence, so it will be nice to go through this document when you're free. As you all know, and I think you've had several lectures already, mortality remains very high among patients who present with advanced disease and those who have serious OIs. Despite 30 years of HIV and the epidemic, it's yet unclear when we should start these patients on ART if they have an OI to help minimize this mortality risk. So despite what we know, we do a lot of things based on expert opinion and not really on evidence. So the rationale for either early or deferred initiation of ART is defined by many potential factors. As you all know, the mandate right now is to start ART, and Kate mentioned in your case that there's actually some evidence to start as early as day 1. But let me show you kind of the pros and cons to starting. Next slide, please. So in this table, you can see the advantages of early start to the left column would be, of course, to prevent progressive immune deficiency. You have more rapid immune recovery because you're on medications. You have rapid resolution of an OI and rapid reduction of mortality risk. And of course, once you start ART, you then help prevent other OIs from occurring. So it kind of sounds intuitively like it's the right thing to do right away. But what are the disadvantages? So when you start ART early, you do have a higher pill burden because remember, you already have an opportunistic infection. So the prime example would be someone with tuberculosis, for example. You have 3 or 4 pills from your TB meds, and then you add 1 pill if you're lucky, or several other pills, increasing your pill burden. The other disadvantage, of course, is co-toxicity, right? So I'm sure you've come across patients where they develop a rash, for example, if they're on multiple meds, or they develop high fever, things like that. And then because they are on multiple medications, you're unclear which medication caused the rash. The other disadvantage is immune reconstitutional iris, and I think you'll have a series on this, or a session on this. It's basically a profound immune response causing fever, like a flu-like syndrome when you're on multiple medications. Again, because of multiple medications, it's very difficult to identify which drug caused the toxicity, and so you're often forced to stop all drugs altogether, which is not what you want to happen. So these are the risks of that you must balance when you start ART. So now, I'm sure you've heard that the mandate right now is like when you do CPR, it's hit hard, hit early. With HIV, it's also the same. So you want an early start. But the problem with that is you have to assess your patient readiness. Is your patient ready? Through experience, it's never a good thing if you are the one forcing your patient to start meds. Never do that, because at the end of the day, it's not going to be you who will be taking the medication, but your patient. And also, as we'll discuss, if there is a concurrent opportunistic infection, then you have to debate whether or not you will do the patient harm if you start ART or not. All right, so we'll go over the first OI, which is probably the most common OI you'll see apart from tuberculosis. So PCP, which is pneumocystis, I know you've already had a lecture on PCP. So what's the evidence in terms of starting ART if you have PCP? So the recommendation, if your patient is not yet on ART, you should initiate ART when possible within 2 weeks of PCP. And this is a grade A1 recommendation, meaning there's very good data to support this. So this is, if you are to remember one study from this session, it'll be this study. It's available to all, it's open access. Just Google Dr. Zolopa and early antiretroviral therapy. So this is kind of the basis of what we do in terms of treating PCP and ART. So briefly, we'll go over it briefly. They randomized 283 subjects with an opportunistic infection or a very severe BI, is bacterial infection. The CD4 was very low, 29, and the median age of the patients in this study was 33. So kind of comparable to our epidemic here in the Philippines. So they randomized the patients to an IA or an immediate arm and to a DA or a delayed arm. So kind of half-half. And then over a year, so 48 weeks is a year roughly, they were able to follow 123 patients in both arms. And what did they find? So they found, in terms of their outcome, that the rate of death or progression of HIV in the immediate arm was less than that in the delayed arm. So with a significant p-value. So in other words, if they started ART, and immediate arm here is a median of 15 days, so about 2 weeks, and the delayed arm is about 45 days, that was the median. They found that if you start ART within 2 weeks, then you decrease the rate of death or progression of HIV at 1 year's time. So that's where we get that evidence. So of note, remember though, that in this study, no patients with PCP and respiratory failure who were intubated were enrolled. So this study is mainly for mild to moderate PCP. So we still do not know the timing of ART in patients with severe PCP who are intubated, right? Because it's very difficult to give them oral ART. We do not have IV preparations here yet. And also we cannot predict the absorption of oral medications. So they are excluded from the study. Take note of that. So leaving PCP, we now go to our favorite OI here in the Philippines. This is tuberculosis, of course. So the key point, one of the key points here is that the timing of ART in co-infected patients, so those who are HIV positive and who have TB, it depends largely on the CD4. So in general, the lower the CD4, the earlier you should start your ART. So in terms of co-treatment, why do you have to co-treat? The bottom line really is it improves survival for patients who have very low CD4 counts, who are very immune suppressed, and decreases the risk of additional opportunistic illnesses, right? What are the other advantages? So again, because you're treating both TB and HIV, you can achieve high rates of viral suppression, you improve TB treatment outcomes, and despite higher rates of iris, at lower CD4 counts, you do not, this is not associated with higher rates of other adverse events. So there is a higher rate of iris, meaning they can get flu-like symptoms or problems when you treat early, but it's not associated with other adverse events. So let's go over pulmonary tuberculosis first. So I wanted to just summarize the evidence in this one table. So there are now 4 randomized controlled trials which have looked at early versus delayed initiation of ART amongst HIV positive patients with pulmonary tuberculosis. Take note, this is just pulmonary tuberculosis, not disseminated TB or extrapulmonary tuberculosis. As you can see in the first column, so the population kind of varied depending on the study. But in general, the CD4 counts were pretty low for the middle 2 studies. For the first and the last study, the CD4 counts were a little bit higher, right? So the intervention again is early initiation of ART versus delayed initiation of ART. Early in general meant 2 weeks, and then delayed initiation meant after 8 weeks or more. No? So the RCT have nice acronyms, SAPIT, Camellia, Stride, and TB Heart. No? In general, in terms of the outcome, so there's mortality benefit with early ART for the first 3 studies. But in the last study, there was no significant difference between between early initiation and delayed initiation of ART. So how about TB meningitis? So this is a different sort of animal altogether. So these are not, the previous studies did not include TB meningitis. So what about the data in terms of starting ART with your patients who have meningitis? Unfortunately, the optimal approach is uncertain, but we do have a little bit of data, so we can help a little bit in terms of timing. Next slide. So this is kind of the study where we base our recommendations to start ART during TB meningitis. It's a pretty good sized study done in Vietnam. It's about 253 HIV positive patients with confirmed TB meningitis. And the intervention was they gave ART immediately within 7 days or 2 months after starting treatment. And this again is a randomized controlled trial. The outcome is a little bit surprising. So when they, with early ART, there was similar mortality and more frequent and severe adverse events compared to deferred ART arm. So what does this mean? This means that you have to be more cautious when your patient has TB meningitis and perhaps not hurry to give them ART. So based on these studies given all together, in general, you want to start ART in all HIV-infected patients with tuberculosis. So there's no question there. The question really is the timing. Okay? So if you have pulmonary tuberculosis and you already have your CD4, if it's less than 50, you want to try to start within 2 weeks. Okay? And if your CD4 is a little bit higher, then you can wait a little bit and start within 8 weeks. So again, you do not have to wait for your pulmonary tuberculosis treatment to be finished. So you don't have to wait 6 months. So the key time points are 2 weeks and 8 weeks. And this is for pulmonary tuberculosis. With TB meningitis, however, if you have low CD4 counts and you want to start ART, if you do it early, you might predispose your patients to more harm, right? There's more severe adverse effects. And you should monitor them closely and perhaps consult with an expert if it's potentially your first TB meningitis case and you haven't seen a lot of them. So now we've gone over PCP and tuberculosis. We'll go a little bit over cryptococcus. No? You may not see it often, but it's out there, and it's actually pretty similar presentation to tuberculosis. So you have to be wary of thinking about this type of meningitis when you come across it. Again, so the recommendation here is to delay initiation of ART at least after completion of your antifungal induction therapy, which is usually 2 weeks. And so you want to try and delay it possibly until you complete your consolidation phase, which is about 8 weeks. So in general, so it's 2 to 10 weeks, you want to start somewhere in between. Some people say 5 weeks, but anywhere between those weeks are okay. And why is this done? So there is, again, some evidence behind this recommendation. Again, a randomized controlled trial. And they use, the treatment here was amphotericin B and fluconazole, which we use here in the Philippines, so we can kind of relate with this study. So the early ART here was within 1 to 2 weeks with a median of 8 days after diagnosis of cryptococcal meningitis. And then ART was, the delayed arm for ART was about 5 weeks, no? Which is median of about 36 days after diagnosis. So the outcome, again, similar to TB meningitis, there was kind of and here it's even worse, so there was a higher mortality in the patients who were given early ART compared with the deferred ART group. So the key point here is if you probably should delay ART with those who have very low CSF white counts, meaning they're very immune suppressed, or those with really high intracranial pressure, sorry, that's ICP. So if you get their CSF fluid, you usually measure their opening and closing pressures, right? So if their opening pressure is very high, then you might want to delay starting ART. Again, as I mentioned, you want to start ART between 2 to 10 weeks after starting antifungal therapy. So in general, in my practice, for example, I start ART during the week 6 to 10 when I see them in the outpatient during follow-up. So in general, if you have a patient who presents with subacute meningitis, there should be red flags for TB and cryptococcal meningitis, and you must exercise caution regarding initiation of ART. So in other words, do not hurry. Huwag magmadali starting ART if you're still trying to decipher what kind of meningitis your patient has. So what are the other OIs? So again, as I mentioned, there's a whole list of OIs, and so I tried to summarize them in a table that follows. Okay. So and put the timing in terms of starting ART beside them. So the first OIs listed there, cryptosporidius, microsporidiosis, and PML, are quite rare. And really, the timing is you want to start ART right away because you want that's the only treatment for them, basically, is to start ART. So PCP we went over, again, within 2 weeks. Toxoplasma, you'll see that too, within 2 to 3 weeks. For MAC as well. But as you see, the others are based on expert opinion, right? There's no good randomized control trial for toxoplasma and MAC, for example. So PTB that you see a lot, again, lower CD4, start earlier, usually within 2 weeks. Higher CD4, you can start a little bit later after induction phase, about 8 weeks time. Now, bacterial pneumonia is very, you see this, people who present with streptococcal pneumoniae, you then want to initiate ART early, but the timing of the early wasn't really specified. If you want me to come up with a number, that's probably still going to be around 2 weeks. Okay, so for syphilis, which will be discussed in the lecture to follow, your lecture on STDs, and for candidiasis, there's actually no special considerations. You can start ART anytime. Okay? Again, for cryptococcal meningitis, delayed ART seems to be better. For CMV retinitis, again, 2 weeks seems to be the magic number. So parang overall, if you remember a number from this talk, it'll be 2 weeks. So take-home message, to reiterate, you have to balance starting ART with other factors. And the other factors are as follows. So again, patient readiness, we did not go over that, but I think that's very key. And perhaps you'll have a session on adherence and patient readiness in the future. And the other mitigating factors in terms of starting ART are CD4, so how low and how high your CD4 is, and of course the presence of opportunistic infections, which we kind of briefly went over with this discussion. And I think that's it. Thank you very much.